Hi everyone, I feel very honored to present here at the International Dupuytren Symposium. My name is Dr. Maitumelo Imeldah Motoroko from the Department of Plastic Reconstructive and Hand Surgery, as well as the Monash University Central Clinical School in Melbourne, Australia. I'll be presenting on the relationship between pre-contracture severity and the effectiveness of collagenase in Dupuytren's disease. I'd like to thank my research team for the hard work. I have no conflict of interest to declare. As you all know, there's no cure for Dupuytren's disease. Open fasciectomy has been the mainstay of treatment in the literature. Collagenase is available as a non-surgical option, and it has been reported to be effective in mild to moderate disease. Patients have got the benefits of returning to work and activities in a short period of time. However, this has not been compared in TBNA 1 and 2 versus 3 and 4 contractures. Our aim was to compare the effectiveness of collagenase in treating digits with pre-treatment TBNA 1 and 2 versus 3 and 4 contracture. We recruited 413 participants through our Dupuytren's disease clinic and Peninsula Health between 2016 and 2020. Our data was retrospectively analyzed. We included adults 18 years and above with Dupuytren's disease, and measurements were obtained from the MCPJ and PRPJ of the involved digits. We excluded those with Palmer disease without any contracture. 2 senior plastic surgeons trained the doctors in our clinic. Digits were assessed and classified according to the TBNA grading system. This here is our intervention using the reconstituted collagenase and local anesthetic. Manipulation was done at 1 week post-procedure. You can see here at the bottom left a paper from our research group showing the effectiveness of manipulation of fingers with Dupuytren contracture 7 days after collagenase treatment. We looked at 2 key outcomes: reduction in digital contracture as well as the patient-reported outcomes. We recruited 413 participants, average age of 66, predominantly males. You can see majority were of Australian European background. We excluded 41 digits with no contractures. Minority were TBNA 3 and 4 classification. Majority were those little fingers involved. So the results, looking at the treatment outcome before and after collagenase, we'll be looking at the TPAD, which is the total passive extensive deficit combination of the MPJ PED and the PRPJ PED. And we'll then look at the clinical improvement, which is the percentage of patients with a reduction in contracture of 50% or more. Clinical success defined by percentage of patients with a reduction in contracture of 0 to 5, and lastly the patient-reported outcomes. So TPED, we can see here that both groups, TBN 1 and 2 and 3 and 4, pre-treatment, what the passive extensive deficit was, and the improvement at 6 weeks and the 6 months mark. So both groups had statistically significantly greater reduction in joint contracture at the 6 weeks mark and the 6 months mark. When p-value is less than 0.05, the joint reduction of TBNA 3 and 4 was statistically significantly greater than that of 1 and 2. So you can see the p-values at those time frames. Clinical improvement. We can see here a higher proportion of digits had achieved a significant clinical improvement in both groups, TBNA 1 and 2 and 3 and 4, and at the 6 weeks mark. And there was no statistically significant change in either TBNA categories at the 6 months mark post-treatment. So therefore the results from the 6 weeks mark were maintained at this point. clinical success, I would like to highlight here that a larger proportion of patients in Tibiana 1 and 2 group reached clinical success compared to Tibiana 3 and 4, with only 13% at the 6 weeks post collagenase. However, there was no statistically significant change in either Tibiana groups post-treatment at 6 months. So this shows that the results were maintained. You can see here 53 and 51 and 13 and 18 in those groups. Patient-reported outcomes. Use of Southampton, URAMS, and the patient set. If we look at these three scales, these are the pre-treatment values that significantly improve with good patient satisfaction at the 6 weeks mark, and further at the 6 months mark with p-values of less than 0.05. If we look closely at Tibiana 3 and 4 group here, there's significant improvement in the URAM scores at 6 weeks and 6 months. You can see here, this shows that the Tibiana 3 and 4 had good response or satisfaction at the 6 weeks mark, as well as the 6 months mark compared to Tibiana 1 and 2. Similarly, in patient sets, you can see here at the 6 weeks mark, which is not statistically significant at the 6 months period. So here, Tibiana 3 and 4 predicted skin splits with odds ratio of 8.4 and a p-value less than 0.05. You can see here with pain and bleeding odds ratios were high, but these were not statistically significant, therefore not predictive. Below here is a paper that's been published recently from our research group, which shows that skin tear post-collagenase treatment had no influence on the effectiveness of the treatment. So here the pre-Tibiana category predicted outcomes. So pre-collagenase Tibiana 3 and 4 digits were statistically significantly more likely to have larger p-values than Tibiana 1 and 2. Similarly, in the clinical improvement, odds ratio of more than 1 with a p-value of less than 0.05, showing that Tibiana 3 and 4 pre-treated digits are more likely to have clinical improvement compared to digits 1 and 2. And this makes more sense because you need larger correction possible in digits with larger pre-treatment deficits. And then lastly, the clinical success odds ratio of less than 1, p-values of 0.05, showing that Tibiana 3 and 4 pre-treated digits were less likely to have clinical success compared to Tibiana 1 and 2 group. Our study shows that collagenase is effective in these two groups at 6 weeks and 6 months, as shown by the TP day and clinical improvement, and also the patient reported outcomes. However, not in clinical success, which is better in Tibiana 1 and 2 than in Tibiana 3 and 4 group. And this is consistent with other studies. Manipulation is safe at 1 week. Our study gives insight into treating severe Dupuytren disease, and it is important to be aware of collagenase-related complications when we treat these patients. These are the strengths and limitations of our study. Obviously, extended follow-up would be important in these patients to determine the recurrence rate in both group post-treatment. These are the references. Thank you. Any questions?
Thank you very much. That's a great presentation. Now, I am just going to promote you up. Just give me 1 second while I fight with the technology. And I'm going to invite you up to be a panelist, Dr. Motoroko. And hopefully you're about to appear. Hi, welcome.
Hello, everyone.
Thank you so much for joining us from sunny Australia. And thank you very much for your talk. I wondered if I could start the questions. I want to sort of flip it round a little bit and ask you how early you start treating your Dupuytren's disease, because certainly in the UK, we're restricted by the degree of angular contracture before we're even allowed to start treating our patients. How early is too early, do you think, for treating Dupuytren's?
Yeah, that's a very good question. We're very lucky enough to have set up, you know, a Dupuytren's clinic. So a lot of patients, when they come through, have already made up their minds, and they have already even met other patients who have gone through similar treatment. So we had funding, even though we know that in Australia that where like collagenase won't be available, but we had less supply over that period of time. So if patients did not want any surgery in any sort, especially the ones that we consider having severe disease, if they want to have treatment, we'll give it to them. And those who have early disease, if they have contracture, we would do collagenase to prevent that from progressing. Certainly those who have nodules but no contracture, we observe them.
Okay, so essentially any degree of contracture and you're happy to treat?
Well, if patients are symptomatic, we certainly would offer them treatment. Yeah.
Okay. What do the other panelists think about that? Is anything too early, Paul?
For me, the essence is a progressive contracture. So if a contracture is stable, then I don't do anything. And that is obviously, I ask the patients if it's getting worse, and if they're in doubt, then I see them again some time later.
Joachim.
I usually advise patients with less than 20 degrees of contraction just to wait, and I tell them that there's a greater risk of recurrence, for instance, if you do it open surgery, and most patients are quite happy with that. So 20 degrees is sort of a cutoff for doing anything, I'd say.
Yeah.
Gary?
Yeah, I totally agree. Like if patients are quite stable, we don't treat them, but certainly a lot of people who come to us is that they have had, progressive disease, and they actually get referred to us because they want treatment.
I noticed your boss, Dr. Motoroko, has just written in the chat that you don't touch stable disease either.
Oh, okay.
I agree.
Thank you, David.
I
Gary,
also agree
yes.
with Paul and David and Joachim. You know, stable disease doesn't need to be treated, especially if it's mild. But once the disease is progressing 15, 20 degrees and beyond, especially a PIP, you know, I try to treat early. I think, you know, the old paradigm of, you know, come back when it's bent and then I'll open you up, you know, with minimally invasive techniques, we try to get them much earlier.
Yeah. Okay. Great. We're starting to run out of time. I think I'm going to move on to our final talk of the evening. Thank you very much, Dr. Motoroko. I'm going to relegate you back to being an attendee. I do apologize. It's always horrible when I have to do this.
Thank you.
But thank you very much for coming along.
No worries. Thank you.